get going with the presentation. So, complete pleasure to welcome Professor Kate Dunn to come and speak to us, which we're very grateful for. Kate is Professor of Epidemiology at the University of Keele, and she's lead for the Keele University Musculoskeletal Health Research Group. I may not have said that quite right. Most of you will know she has a huge profile and many years of experience in looking at back pain, musculoskeletal pain in children, adolescents, and with a particular focus on primary care. So thank you very much for coming, Kate, and I will let you take it away.
Thank you very much, Jeremy, and thanks everybody for attending today. So as Jeremy said, I'm Professor of Epidemiology at Keele University, and I'm going to be talking about the epidemiology of musculoskeletal pain in children and young people. And so to start off, I just want to give a little bit of a background as to how I came to be studying musculoskeletal pain in children and young people. So I started out studying mainly back pain in adults, and we did a number of studies in adults looking at people who went to see their GP about their back pain, and then we followed them up over periods of time. And what we found was that actually people don't change very much over time. So if you get adults in, and individuals may fluctuate up and down, their pain may get worse and may get better, but they tend to have a mean around which they fluctuate. And when we did this study of adults going to see their GP about back pain, you can see there's 4 groups here that we identified using something called latent class analysis. And people tended to stay in their group. So we did the analysis over the first 6 months, and people were in those groups for that period. And then we followed them up to 12 months, and people still stayed in those groups predominantly. A few people may have improved slightly, went down to a lower group, but generally, if you were in a severe chronic pattern of back pain, your pain may fluctuate a little bit, but actually over a year period, your pain tends to stay about the same. And we also followed this group up 7 years later, and actually 7 years later, most people were still in the same group. So not much is happening at all. We tested it out in another study, and we followed them up for 5 years, and we found the same thing, that actually not much is changing in adults with back pain. And when you look at other musculoskeletal pains, this is quite similar in adults, that they don't change very much. But when you talk to the adults, what they often tell you is that, oh yeah, but you know, my pain started when such and such happened when I was younger, and oh, I've had pain on and off for 30 years. And they'll tell you these stories that fit their pain experience, not to an episode, not to when they went to the GP, but to a whole life course. And so it got me to looking at using a life course perspective for musculoskeletal pain. So this is based on the principle that factors influencing your health occur throughout your life, and particularly different stages of life. So this may be in childhood or adolescence and across your adult life. And during your life, there are what you may think of as critical or sensitive periods that are points at which there are crucial times in development. So points where something that happens at that point may have a big influence on something that happens later. And this life course approach to epidemiology has had a large influence in other conditions such as cardiovascular disease, and lots of understanding has improved as a result of taking a life course approach of looking at other diseases. So I decided to start to try and look at a life course approach to looking at musculoskeletal pain. So this is a hypothetical diagram that shows all the different things that may be going on in somebody's life when sometimes they happen, sometimes they're there, sometimes they're not. People have periods where they're very happy, periods where they're not so happy, periods where things happen. And alongside that, they may have episodes of pain as well. And those episodes of pain are influenced by all the other things that are going on in their life and all the other things that have happened previously, including their previous history of pain. So looking at that is what brought me to studying children, because it seemed that even if you look at adults, younger and younger adults, it's still the history of pain that's one of the biggest factors associated with future pain occurrence. So we decided to start to go back to looking at children and young people. And so this is just a basic overview of the prevalence of musculoskeletal pain in children and young people. And the figure at the bottom is 1 to 2% of children are likely to have chronic disabling pain. So that's pain that is severe, long-lasting, causes them to seek healthcare, and these are the people that many of you will see in your chronic pain clinics. But they are absolutely the tip of the iceberg of all the children that are out there with musculoskeletal pain. So just above this 1 to 2% is the figure of 8%, and that's our estimate of the proportion of all children in the whole population that go to the GP each year with a musculoskeletal pain complaint. So that would include back pain, neck pain, knee pain, foot pain, shoulder pain, ankle pain, all of these different pain sites. So we think that around 8% of children go to the GP each year with a musculoskeletal pain condition. But not everybody goes to the GP. So there are plenty of children out there in the community who already have pain and don't seek healthcare for whatever reason. So the estimates vary very widely in the general population. There are estimates of persistent musculoskeletal pain of about 15%, and estimates of chronic musculoskeletal pain are around, they vary from 4 to 40%, which is obviously an extremely wide estimate. That is different because it's based on different definitions of chronic pain, different populations, different age groups, different samples that they include. And we're not going to get an absolute figure of the number of children out there who have chronic musculoskeletal pain. And similarly with all musculoskeletal pain. So the estimate is probably about 30 to 60% of children and young people will tell you that in the last month they had some kind of musculoskeletal pain. So for many of them, this will be just a sore knee from when they were playing football and they hurt themselves, and it goes away on its own and they don't need to seek healthcare. So, but the main thing to emphasize here that it is so common. It is really, really common. If you get a class of 30 children, in all likelihood, 10 of them will have had musculoskeletal pain in the last month. And they'll be able to tell you about their sore knee, or their back started hurting, or they had an aching foot. And so in the population, it is really, really common, but we don't know that much about what impact it has on people. The next slide, this slide is just an indicator of how varied the estimates are. So this is a paper that took the better quality evidence for the prevalence of back pain and other musculoskeletal pains. So if you ignore the numbers in the diagram, but just look at the bars, and those bars are estimates of the prevalence. So you can see how widely different the estimates are from different types of studies. But the best estimate is probably about 1 in 3 children will have pain over the previous month or so. But these figures are just very broad. They don't really tell you a lot, because pain obviously varies according to pain sites and by other characteristics of the individuals with pain. So the first thing that I wanted to talk about was the prevalence of pain by age. So these are just 2 examples of studies that have presented data on the prevalence of musculoskeletal pain by age. So in the first graph on the left, you can see that this shows the prevalence of low back pain from 11-year-olds up to 14-year-olds in boys and girls. So what you can see is that there's a rising pattern of back pain from 11 to 14-year-olds, and that generally it's higher in girls than in boys. And on the right, another graph looking at knee pain. That shows a slightly different picture. It's definitely a rising trend from the 9 to 10-year-olds up to the 14 to 15-year-olds. And knee pain is more common in the older girls than the older boys, but in the younger age group, it looks like perhaps knee pain is slightly more common in the boys. So this shows the importance of not just looking at the one single figure, the prevalence figure, actually looking in a little bit more detail. Generally, what you will see for all musculoskeletal pains is a general rise from childhood to adolescence in the prevalence. So they're much less common in the younger people, and they get more and more common as we get older. But we don't have that much detailed data on this, because you need very big studies to produce the data for boys and girls separately, for different pain sites separately, and for different age groups separately. So we're looking really at a general pattern. So that's a sort of overview of the prevalence, but how do people get the pain? What are the risk factors for this musculoskeletal pain? So risk factors are things that are believed to be present before the pain is happening, and they are factors that increase somebody's likelihood of experiencing or developing musculoskeletal pain. So these are risk factors in children, and these are taken from a series of systematic reviews. So they're summaries of all the evidence in these areas. So there are some things that the systematic reviews are saying are quite consistently associated with the onset of musculoskeletal pain. So children from low socioeconomic backgrounds are more likely to develop musculoskeletal pain. Children who have experienced or reported negative emotions, so things like depression or distress, are more likely to develop musculoskeletal pain. Also, things such as smoking and adverse childhood experiences. Children who smoke, and there are other factors similar to this, are more likely to develop musculoskeletal pain. Now, this doesn't necessarily mean the smoking is causing the pain. What it means is that the children who smoke are also the children who are more likely to develop the pain. You can't demonstrate a cause and effect relationship for any of these necessarily. And another important factor that is quite clearly associated with the onset of pain is a history of pain. And that is true whether the history is in the child themselves or whether the history is in the family. So if a child has a parent who has experienced musculoskeletal pain, that child is also more likely to experience it. But there are also a number of factors that these systematic reviews have found are not associated with the onset of musculoskeletal pain. And some of these might be quite surprising, that people might expect them to be associated. So the first one is sleep problems. So this may be problems getting asleep or staying asleep. And the evidence shows that actually these are not associated with new onset musculoskeletal pain. Similarly, the evidence isn't there to show that children with hypermobility in their joints are more at risk of developing musculoskeletal pain. So remember, there may be individual studies that show these things are linked, but when the overall evidence is looked at in a systematic way, these are showing that they are not linked with new onset pain. So other things such as taller height and high BMI are also not associated. And the weight of a school bag is another thing that people often think may be associated with developing back pain, for example, but that's not what the evidence is showing when you look at it as a whole and combine results from a number of different studies. So there's some things that you would expect there, and other things that perhaps slightly more surprising that are not risk factors for pediatric pain. So once you've you've got the pain, once a child has got the pain, what's likely to happen to them? And so for that kind of information, what we're interested in is the prognosis, or whether the pain is likely to persist. Now, there are fewer studies looking at the persistence of pain and prognosis, but there are some studies available, and they generally show that actually in the people that are included in the studies, it's quite common for the pain to persist. So up to half of the children and young people with general musculoskeletal pain are likely to say that over the next 1 to 4 years, that pain is still persisting. That doesn't necessarily mean the pain is having an impact on their life. It doesn't necessarily mean it's causing them to have time off school or to seek healthcare or anything like that. But it does mean that they are telling us that their pain is still there. But like I say, there aren't a huge amount of studies looking at this. The data may be, as more studies are coming out and more people are doing these kind of studies over the years, then there will be more evidence about how often the pain persists. But knowing that it persists doesn't still tell you an awful lot about actually what's happening. And so one of the studies that I've done has looked at trajectories over time in adolescence. And if you remember the slide I showed at the beginning with trajectories in adults, and that showed pretty much the same pattern over the whole period. And when you start to look at young people, the same thing isn't true. There are definite patterns of people developing pain over time. There are patterns of people recovering from pain, and there are different things going on there. So the graph shows the probability of pain, and these are different groups of people who've been identified with different probabilities of pain. So at the top, you can see a small group that have a very high probability of pain throughout the follow-up, but that group was only about 1% of the sample, so it's a very small group. In red in the middle, you can see a group that develops pain quite early on. So these are 11 to 14-year-olds. So these are children developing pain between about 12 and 13, that by the time they're 14, it's actually improving. And so that group is, again, quite a small group. And the vast majority of children in the general population will fall into the cluster at the very bottom that shows that they're very unlikely to have pain throughout the whole time period. So most of them don't have pain most of the time. Some of them have pain and then recover. And then there's these few groups that do have pain that changes over a period of time. So this was a study that I did looking at adolescents recruited in a population in the United States. More recently, a study was published looking at children and adolescents in Australia, and that actually showed some of the similar patterns. So again, there was a group who developed pain at about 11 or 12 years old, and then they improved over the following year or two. And this study also showed that the vast majority of people either had no pain or had the occasional episode of pain during this time period. So again, what this is showing that in children and young people, there are different patterns of pain. It shows that most people don't have pain that lasts for long periods of time. Most children, probably 3/4 or 80% of children, will just have the occasional episode and they'll be absolutely fine. But then there are these other groups where the patterns of pain are changing over time. So once people have got this pain, once children have got the pain, what factors are associated with whether they recover or not? Now, these kind of factors are important because these are children that have got pain. They may be children who are seeking healthcare, and knowing about which factors can influence whether somebody improves or not can change the conversations between a person with pain and their clinician. So there are a number of factors that have been identified, again, from systematic reviews, but again, with limited evidence from not a huge amount of studies. So just looking at the factors identified here, so some of them are probably not that surprising, particularly to those of you who work in pain clinics, for example. So negative emotions such as anxiety or depression increase the likelihood that pain is going to persist. And some factors associated to do with the presentation of pain at the beginning. So whether the pain has got high intensity when the person is seeking healthcare or is presenting, whether they've got a long duration of pain when they first turn up, and whether they've got activity limitations. Those things are all linked to whether somebody is likely to have persistent pain or not. In addition, older children are more likely to have pain that persists, and females are more likely to have persistent pain, and some other things such as daytime tiredness and sleep problems are more likely to be associated with whether pain persists over time. Some of the newer data that hasn't been included in systematic reviews at the moment show that some of the adverse lifestyle behaviours can be associated with pain persistence. So this is things like low physical activity or smoking or alcohol. And this is still in children. This is children who report these adverse lifestyle factors. But there's one factor that comes out as fairly consistently not associated with worse outcomes, and that's BMI. So children with higher BMIs are no more likely to have pain that persists than children with normal, for want of a better word, BMIs. So that may be something that isn't necessarily commonly known, but the evidence is fairly consistent across different studies that BMI is not associated. So, given an outline of what's happening in the general population and in population studies, but a lot of the work I've done has been in the primary care setting. So this is normally the setting where children will first seek healthcare. This is where they go to first, they get a pain, the pain maybe starts to cause them some problems, or they can't do something, or it's getting worse, and then they'll go to the GP to find out what's going on. And this is where there is less evidence out there of what's actually going on. So I'm going to present the evidence that is available, and then I'm going to talk about some hot off the press evidence that we've got from studies that we're doing here at Keele. So this is data from Australia. This is data on musculoskeletal conditions presenting to primary care in children and adolescents. What this study doesn't have is knowledge of the whole population. So they can't say this % of children are presenting. What they can say is that this proportion of consultations are due to musculoskeletal pain. So what this graph shows is that in the 0 to 4-year-olds, only about 2 out of every 100 primary care consultations are due to musculoskeletal pain. And this rises over time, particularly in the boys in this data set. So in the older age groups, it's about 14 to 16% of all primary care consultations are due to musculoskeletal conditions. So this is giving an indication of the increasing proportion of consultations, but it doesn't give us an awful lot of information about what proportion of all children are consulting. So this is data from a few years ago, looking at a relatively small database of primary care consultations in the UK. And so we looked at what proportion of all children registered with a GP practice, and in the UK 98-99% of people are registered with a GP, is probably even higher in children. So this is a population consultation prevalence. So you can see in the 3 to 5-year-olds, there's very small numbers of children seeking healthcare for musculoskeletal problems, but this rises from the 6-year-olds right up to the 17-year-olds. and it is consistently slightly higher in males than females. And overall, it's around about 8% of children are consulting a GP about musculoskeletal pain in any 1 year. If we just look a little bit more into what they're actually consulting about, so in this graph, the consultations have been grouped into consultations that are pain, coded as pain consultations. So this may be something just listed in the records as backache or knee pain. And then in the red, you can see consultations coded as trauma. So this could range from a twisted ankle to a broken leg or broken arm or something like that. In green, it's coded as problems, and that's likely to be specific diseases such as Perthes disease and hypermobility. And finally, the other is very specific, rare deformities that a GP has coded them as. But you can see what the graph shows very neatly is that actually the consultations for trauma don't change very much between 7-year-olds and 22-year-olds. It goes up slightly, but it's fairly consistent. But the consultations for pain rise rapidly in that age group. So from being relatively rare in the 7 and 8-year-olds, when you get up to the 22-year-olds, then pain absolutely dominates all the musculoskeletal consultations. So how have the consultations changed over time? So I'm not going to go into the details of this graph. This is quite a sort of epidemiological graph, but basically each line represents a different cohort of children who were born in a different year. But they're plotted on the graph by age and by the musculoskeletal consultation prevalence. And what this shows is that you can see the prevalence overall is rising from 7-year-olds right up to 22-year-olds. And this isn't different for people born in 1988 compared to people born in 1996. That there's no change over time in this trend. This trend has always been there, and it's still there now. So it just shows that there's a very clear trend in the consultation prevalence with age groups. So moving back to some of the Australian data here. So this is looking at the two most common musculoskeletal reasons for consultation in children and young people. So the two most common regions are lower limb pain and spinal pain. And so you can see in the graph, the solid lines are for spinal pain with boys in green and girls in red. And there is definite increase in the proportion of encounters over age for those. And for lower limb pain, the pattern is slightly different. So it increases up to about 14-year-olds, but then the proportion of encounters that are due to lower limb pain falls. So there seems to be a sort of a peak happening at about 14 years old in lower limb pain. Moving on to a little bit of data from Sweden. So this again shows the most common musculoskeletal pain sites consulted for in Sweden, and this is consultation prevalence. So this shows a very low prevalence in the 1 to 12 year age group, rising up to much higher in 13 to 18-year-olds. And then for joint pain, much of which is likely to be knee pain, is leveling out from 18 up to the 24-year-olds. Whereas for back and neck pain, this is increasing right from the youngest age group to the oldest age group. What you can see at the bottom is lines for persistent pain. So persistent pain is rarely coded in general practice. It is probably slightly more coded in Swedish general practice than in UK general practice. So in the UK records, it is almost impossible to identify any codes for any kind of persistent or chronic pain. The codes are generally for pain site. So this is data from Denmark that is from a small cohort of children who visited their GP with musculoskeletal conditions. So these were children aged 12 to 16 years. And in this age group, you can see very clearly that knee pain is by far the most common pain site consulted for. And but after that, actually, ankle, heel, and foot. So foot and ankle pain is very common too. And then in this age group, in this sample, back pain is the next sort of group of consulters. So again, they're the most common pain sites that we can see in this Danish sample. And this is again back to the UK, and we can see the same thing, that foot and ankle pain is the most common pain region consulted for in children aged 3 to 17 years, followed by knee pain and then back pain, with other pain sites being much less common. And if the pain site that you're interested in isn't mentioned, that's because it's even less common. So things like shoulder pain are very rarely presenting in primary care for children. Foot and ankle is clearly the most commonly presented pain region consulted for. So this is an analysis looking specifically at knee pain in UK primary care. And this shows something similar to the Australian data. So it shows that there's an increase in knee pain from 3-year-olds right up to 14, 15-year-olds, and then a drop off around going down to the older age group, so 16 to 17 years. So you can see some different patterns emerging here. And so one of the patterns was back pain. So this is data again from a relatively small UK primary care sample. And what this data shows is the prevalence of back pain consultations for children and young people in UK primary care. And what you can see from almost no consultations in the 17-year-olds, there is a clear increase with age. And that doesn't stop at 18. This data only went up to age 22. But clearly the prevalence is rising right the way up. But you can see a few wobbles in the line. There wasn't that much data there. So I'm just going to move on to some data now from a study that we've got ongoing. So this is hot off the press. This isn't published yet, but this is data from a much larger sample. So this is data from a research program that I'm leading, and we're using the CPRD, which is a very large database of primary care consultations, mainly from England. And the data that we're using is based on around about 1.9 million children. So it's quite precise, and we are able to look at it in a lot more detail than previous studies have done. So this graph is showing trends in consultation over time. So what you can see from 2005 up to about 2015, there's a broadly increasing trend in the consultation prevalence for musculoskeletal pain. So this increases from around 8% up to about 10% in 2015. And then there's a slight drop off to around 9.5%. Broadly, you can see that the prevalence is higher for females than for males. So the green line is females and the black line is males. I'll perhaps ignore the first few years where it's very close. It looks slightly like males are higher than females, but we think that maybe an issue with the data from those years. But broadly, you can see that it's higher in females than males. And what you can also see here is the rapid drop off in 2020 when the COVID pandemic hit. So the number of children and young people visiting their GP for musculoskeletal pain in 2020 dropped rapidly down to around about 5.5%. And that increased slightly from up to 2021, but still nowhere near up to the pre-pandemic levels. We don't have data from 22 or 23 yet, I imagine they will carry on increasing back up, perhaps even exceed pre-pandemic levels, but we really don't know that yet because that data is not available. So overall, there is an increasing trend over time. There are more children going to the GP with musculoskeletal pain, but it doesn't appear to be still increasing. If you ignore the 2021 data, then up to 2019, you've got about 9.5% of children and young people visiting the GP each year with musculoskeletal pain. Now, this next graph is very busy, but I'll try and talk you through it. It's very busy, but it's very interesting, I hope. So what this graph shows is the consultation prevalence, so the proportion of children visiting the GP for musculoskeletal pains. Each colour on the graph is a different age group. So the dark brown at the beginning is 8-year-olds and the pale green at the end is 18-year-olds. And it's divided up for the 5 most common body sites consulted for. So that is back pain, chest and trunk pain, foot and ankle pain, hand and wrist pain, and knee pain. So these are all musculoskeletal pain. So this is chest or trunk pain that's been coded as musculoskeletal pain. And on the left, you can see females, and on the right, you can see males. So overall, you can see the most common pain site is foot and ankle pain. And this seems to be peaking around 11 or 12 years old and then dropping right off as it gets up to 18-year-olds. So we don't know exactly what that means, but it seems likely that perhaps these foot and ankle pains are to do with pains to do with growth. We don't know the prognosis at the moment. We don't know how many of these are actually impacting on the children. But this is a very different picture than you would see in adults. In adults, you rarely see foot and ankle represented among the most common pain sites. So this is something very specific to children. So the final group on the graph is the knee pain. So you can see here that knee pain increases rapidly until about 13 or 14 years old, and then it starts to drop off again. So there's clearly a peak in consultations for knee pain around about 13 or 14 years old. Now, this, you may have your own ideas about why this may be. This may be due to sporting injuries, or it may be a different type of growth pain in a different age group. But it's clear that there's a peak around 13 or 14, and then it's dropping off. Hand and wrist pain is showing some kind of peak around 11 or 12 years old and then dropping off. But the difference between the lowest and highest prevalence in age groups isn't that different for hand and wrist pain. But back pain, I think, is probably one of the most interesting ones on this graph. So what you can see is an increase in back pain prevalence from very low levels in the 8-year-olds up to very high levels in the 18-year-olds. And this is particularly true in girls. So in boys, once they get to about 15, the back pain prevalence seems to stay about the same, whereas in girls, it just keeps on increasing. I think this is showing something very new and very interesting, because the way that you can interpret this is perhaps that there's a different etiology to back pain compared to the knee pain and the foot and ankle pain. We don't know what that is, but it's certainly something that we'll be looking at. And we've got a lot more work planned using this data set. And we're going to be able to look at how many of these children and young people get referrals and how many receive medication, and what their prognosis is. So we're going to be doing a lot more data. And because we've got such a huge data set, we're going to be able to look at this for the different age groups and for the different pain sites and for boys and girls separately. So there's lots more work to be done. But I think this is showing in a much more precise way than the previous research exactly what the trends are for different pain sites for musculoskeletal problems. So I showed you previously the prognosis work for the general population studies. And the problem is when you start to look at prognosis in primary care, there are almost no studies. So a systematic review from 2019 found no primary care studies looking at the prognosis of musculoskeletal pain. There have actually been a couple of small studies published since then, but it's certainly an area where we don't have much information. And without the information about prognosis, then it's difficult for the GP to make the decisions about who might need to be referred, who might have persistent problems, who needs extra care, who can just be reassured and sent away. So this is something that we're hoping to be able to look at, but it's something that there's almost no evidence about. And without this kind of evidence on prognosis, it's very difficult to know how to treat the children and what kind of treatment they might be best with. So it's important information that really is completely missing. So that's all the data I'm presenting. If I just finish with a slide that shows the research that we're doing. So this is the program of research we're doing is the campaign program. And we're currently recruiting children who've been to the GP with musculoskeletal pain. And we're also trying to recruit healthcare professionals who treat children with musculoskeletal pain in primary care. So if there's anybody watching who is involved with the treatment of children and young people in primary care, then do get in touch and you may be able to help us getting involved in a focus group or something like that. Thank you very much for your time, and that's all I've got to say.
Okay, thank you very much for that. I think we can all imagine a virtual round of applause going on in this slightly strange format. So that was great. There were some questions that came through, so I hope, if you don't mind, we could have a little look and address some of those. So first of all, you put some really interesting data about the frequency of pain and about some of the things which aren't associated with pain. What do you think is some of the common understandings in healthcare professionals? Do you think most GPs or primary care professionals would be surprised about frequency? And do you think that some of them are still repeating the stuff about height and BMI, which somebody pointed out can make people feel very helpless?
We don't know that. That's one of the reasons we're trying to talk to GPs to find out what they do and what their understanding is. I suspect GPs don't, although the prevalence is around 8%, that's 8% of children. That probably means a GP might only see a child with a musculoskeletal pain a few times a year, really. It's not going to be that common. So they probably don't see that many of them. And I should imagine their main thing is just making sure there's nothing seriously wrong. So I can't really answer the question because we don't have any of that data from GPs. They are more likely to know about adult musculoskeletal problems, so they may have a bit of a sway towards their understanding from adults, but I really don't know.
Thank you. So another question, if you'll forgive, is a slightly double-barreled one. So what might be the mechanism whereby negative affect could cause either onset or persistence of pain? Does anybody have any theories? And I suppose in pain services, we've moved beyond the sort of psychosomatic theory of pain, but does anybody, as one person put it, still think it's the other way around, that actually these people are having distressing lives and this kid's just reporting pain as a consequence?
It's an interesting question. Most of the work I've looked at is just reporting that association. So it's not necessarily showing that one causes another. It may be that there are other things that are actually causal in that association. But I think we need a lot more detailed studies trying to unpick what it is that is causing these associations. It may be that people with the negative emotions behave differently when they get pain, and they may have different beliefs and different expectations about what will happen to them, and they may be related to the outcomes. But I think it's quite difficult to say when we don't have that detailed knowledge. But there are certainly associations there, both with the onset and with the prognosis. So there's definitely things going on. And actually, when you talk to young people, they recognize that, and they recognize very clearly that when they're feeling stressed or upset, then their pain is worse. So the mechanisms is perhaps something for a different type of researcher to look into.
I thought as much. I was just pushing you to have a guess and a punt on all of our behalves, you know. And
I think, from my point of view, I suspect it may be about their beliefs and understanding, and leading to the way that they behave in the face of having a sudden onset of pain.
Got it. So if you'll forgive me, I'm just going to read in the chat box, because I think something has just come through. So here's one that's come through from Holly. If we know that activity limitations are a prognostic factor, can we decrease a young person's likelihood to progress to persistent pain if we address and adapt how they participate in activity sooner?
My guess would be yes, but I don't think there are any studies that have tested that. I suspect this comes back again to the beliefs and the behavior. So it may be that children who are quite happy to carry on with their activities when they're in pain do better, and children who they may have worse pain, which stops them doing the activities, or they may have beliefs that make them think they shouldn't do their activities when they're in pain, and they're the ones that do worse. So yeah.
Thank you. I realize we are asking you to speculate here. Now, I've got one last infuriating question, which may demand on you to speculate as well. But the extraordinary curve between age 7 and age 22, which has come out in a couple of different places, and it was lovely to see you break that down as to whether that was probably to be a back pain increasing curve, because other things seem to fall away. Right, here's a really big, huge speculative question. What is that about? What is that about? Why are we seeing this huge linear increase? So yes, we see that trauma is flat across the bottom, but I guess if you've got a small percentage chance of trauma every year, then you will accumulate traumas between the ages of 7 to 22. Do we think that's what's happening? It's just simple accumulation of damage, and then some people just get stuck? Or do we think there's something about reporting, or do we think there's something about central pain mechanisms? I know I'm asking you to, again, a question you won't know the answer to, Kate, but it's really, really interesting to hear you speculate as opposed to anybody else.
Well, I know a little bit about the answer, because what we do know is that the prevalence and the incidence are almost the same, which means that most people who seek help from a GP only do it once in quite a long period of time. So it doesn't look like people have one trauma one year and one the next year and one the next year. It doesn't look like an accumulation to me, because it's not that common for people to have repeat consultations. I suspect there's a number of reasons for this particular rapid rise in back pain. I think it could be to do with psychosocial factors and changes in mental health over the period of time, or changes in social support. Equally, it could be due to changes in activity. So it could be from being sort of active 8-year-olds running around and doing lots of sports, to doing less and less sport and becoming more sedentary and having more screen time over time. It could be hormonal, as hormones kick in and puberty happens throughout that whole period. There could be those kind of influences. So I think there's a number of reasons, and I don't think we've got a strong indication of which of those is the most likely. It may be that they all interplay, but I don't think we can really, at the moment, unpick what that is.
Thank you. It's just such a striking graph, though, isn't it? You know, the fact that it seems to fail to stop at any age or even slacken is interesting.
Yeah, it is. And so one thing we're hoping to be able to do is to begin to expand that into emerging adults and look at when it does start to flatten out.
And it does argue potentially for difficulties in our services, which have so many different breaks at age 16 and 18, whilst this prevalence seems to sort of carry on uninterrupted.
Yeah, and I think talking to young people, I think they find the change in services from child to adult services very, very difficult. So I think, there is certainly an argument for having services that overlap and children or young people can move into the adult services at the time that's right for them rather than at a particular age.
Thank you. So listen, I'm going to give one last call for anybody who is willing to type furiously and get a question into the chat box. Let's see if anybody's got anything left. And in that case, I think, failing that, just really many thanks, Kate, for that. It was terrific, really helpful from a tertiary perspective. Extraordinary to hear about the work on samples of 1 million plus, yeah, more power to your elbow. So thank you very much. I'm sure there's a round of applause from everybody going on in the background here.
Great, thank you for inviting me.
Thank you. So for everybody else, keep an eye out for, we will have another pain forum coming up in the autumn. Oh, there's lots of nice comments coming through in the box. That's lovely. And we will send around a link, for example, to the video recording, and also in case you want to just put us any questions or be put on our mailing list if you're not one of the people who is glued to Twitter the whole time. So thanks very much, everybody. We will hope to see you again in the autumn, and we will say goodbye for now. Thank you. Bye-bye.